Y'all started so we can get that work done in the next 2 hours. I'm sure Zimmerman will be here any minute. I don't have any text messages about challenges. So anyway, Chair, take it.
Yeah, thank you so much, Jillian. Good morning, everyone. Thanks everyone for taking the time to be here this morning. We're going to start off with just some introductions, but before that, I just wanted to review the agenda. Mindy Statlander, thank you so much for you'll be providing some updates around Medicaid this morning, which will be great. Then we'll move into the conversation, continuing our conversation around KPIs. And then we'll talk about some next steps after that. So why don't we start with introductions? And Ryan, do you want to start and just go around the table?
Sure, I'd be happy to. Good morning, everybody. My name is Ryan Divert. I use he, him pronouns. I'm the Deputy Director of the Homelessness Response System. Really glad to be here with you all this morning.
Morning, I'm Lori Kelly. I usually pronounce by the financial manager department, Multnomah County.
Hi, Mindy Statlander, I'm the CEO of Healthcare.
Kevin Singleton, Multnomah County Commissioner for District 2.
I'm Maggie, CEO of
Morning, everybody. Anna Allen, she, her pronouns, and I am the SHS taxpayer community member.
Jessica Bacon Peterson, she, her pronouns, Multnomah County Chair.
Mayor Travis Sobel of Gresham. Needed to qualify. There are two mayors.
Peter Andrews, CEO of Milmar Companies. Business rep.
Laura Suarez, she, her pronouns, behavioral health expert.
Kelly Shoney, she, her pronouns, Director of the Homelessness Response System.
Maggie Lynn, she, her, the policy advisor on the homelessness response system.
Robin Johnson, she or they, or you can use my name, policy advisor, homelessness response system.
Thanks, everyone. All right. So that with that, I will turn it over. Mindy, there's been a lot going on around Medicaid, so I'm going to turn it over to you to listen.
Yeah, thank you. And I probably won't take 30 minutes, but I just asked for a minute here because I think part of the reason you wanted to share around this table are organizations like ours, and I'm following in Ivory's footsteps here, is because we have a significant part to play in the resources and support for people who are living in or at risk of homelessness. And so what happens in our system affects all of us around the table. And so I think all of us, or all of the community, is counting on us as accountable systems to communicate with each other and to understand the dynamics and challenges that are happening within each of our systems, so that at the end of the day, we do as good a job as we possibly can to show up together to take care of this population. So I think you are all aware of this, but Oregon has a really long history in Medicaid of managing to a rate of medical inflation that is far lower than what happens in the rest of the country. If you've heard the 3.4% rate of growth, if you're in and around health policy spheres, what we tried to do at the beginning of coordinated care organizations is to manage at 2% less than what was at the time medical inflation. And so by and large, we have been really successful as a state in that. It's a really big deal. It is a national model. The things that were put in place around local governance and community accountability, pointing towards outcomes, utilizing the prioritized list of healthcare services, all of those things have gotten us to the point where we have built a pretty robust but sustainable Medicaid system in our state and our national leader. So in Medicaid, nevertheless, like we had a pandemic that happened, and just like with many of the systems, there were at the same time like a constriction of resources and additional resources at the same time. So for us, enrollment increased, and because of the shutdown of clinical services, service utilization decreased. People didn't use as many services. And so we put our focus into stabilizing access for people in much needed clinical services, making big investments in closing gaps in the traditional healthcare system. But at the same time, costs were increasing for community providers to deliver care, things like inflation and wage growth and all of those things. So also during that time, all of us, the county, the city, Health Share, Care Oregon, the legislature made really big investments in the behavioral health system, both in provider reimbursement to make those jobs more attractive and in straight out behavioral health capacity. Though those were more focused on acute mental health, we still have a lot of work to do in the substance use disorder system. Those things were critical to this work. And over the last 18 months, we've been seeing pretty significant increases in utilization in the healthcare space, first within the behavioral health system, and now we're seeing it in physical health services. And there's lots of reasons for this. Partially it's because the investments that we all made were working and people are utilizing services. That's a really good thing. Partially on the Medicaid side, it's because we went through redetermination. So during the public health emergency, everyone who got enrolled in Medicaid stayed on Medicaid through the end of that. And then we went through and made sure that everyone who was on Medicaid still qualified for those set of services. And on average, the people that stayed in services utilized more healthcare services than those who ended up coming off. But Oregon did a really good job in preserving access to health insurance through that time. It's also from expected things like delayed care from the pandemic, a worse than expected flu season. And then for us locally, because of some of the things we've talked about in this committee, people that need homeless services have a higher risk of behavioral health conditions, are facing consequences to their physical health and are needing more hospital and emergency room services. So super complex set of drivers for increasing utilization. But for Health Share, what that means is that we've experienced pretty significant financial losses last year and this year. And when I say financial losses, for us, that means we're paying a lot more for Medicaid services than we receive as a contract from the Oregon Health Authority. We just went through a rate setting process. And though Oregon has made pretty unprecedented increases relative to historic rates, so we're well above that 3.4% rate of growth that we want to be under, we are still predicting some pretty significant losses going into 2026. At the end of the day, as a nonprofit community-based insurance provider for the Oregon Health Plan, it's totally expected to have losses. Sometimes that's what insurance is there for. But we're hitting a level of significance this year and heading into next year that where the current costs are not sustainable. And this isn't just a Portland metro area. This isn't just a Health Share issue. This is a statewide issue, and it's frankly a national trend that we're seeing in Medicaid. Lots of states are dealing with this. And this is all before the impact of HR1, which will both reduce federal revenue into our state and make it more difficult for people to stay covered. So things like the work requirements and more frequent redetermination. I will say our smart people at the state and in the governor's office are starting to work on how to mitigate harm in the implementation of that, really think through how we balance that. But nevertheless, that is a front on our horizon that we really need to be aware of. But I know also that city and county budgets have been impacted and hard decisions are being made about what to preserve. Ivory shared what's happening with Home Forward, and I just wanted to be transparent that we're having some of those same conversations within the Medicaid ecosystem. For us and our board, those decisions are being guided by values around focusing on the most impacted communities and understanding the role that OHP plays in the larger safety net system. And given the challenges, like we're not always going to be able to balance those things all the time, but I think as those headwinds are coming at us, my hope is just to share with this group so that as we are getting even more focused through the KPI conversation, that we can get really clear-eyed about protecting and preserving what matters most and what's most critical as we have to get back to the basics of solidifying the fundamentals of our system. I feel like I should say all members, OHP members, Health Share members still have access to the full Oregon Health Plan benefits, includes medical care, primary care, specialty. None of that is changing, but we're talking about the individual that we're able to provide, but is not necessarily required. OHP programs. So just wanted to share.
Thank you, Mindy. I know those are going to have a lot of impacts for so many people in Oregon, and especially in this region. So thank you for sharing that. And I know you're working on it. No, we're going to continue to have conversations about those impacts. Any questions?
Yeah, could you share, I mean, you touched on what are those extra, what does that extra kind of services look like? Give me some examples of them.
Yeah, they are, above and beyond sort of community prevention programs, things that do additional care coordination above and beyond what is required, those sorts of fill in the gap services. that we've been able to provide and we know matter to people, but are not part of the core. Go to the doctor, get a prescription, make sure you have classes, go to a specialist, all of those things.
And a lot of those are, have a real impact on our community members. Like for the county, this is going to have a big impact on when we think about like the things that we do that are more upstream or that are ancillary to direct medical service, but really make a difference in terms of people with access care or get on a path to more stable lives. So there will be a lot more conversation there.
Like, I guess I'm wondering if that connection you bring up with like our own county clinics, so like in terms of this reimbursement model, is this affecting that at all for that QHC stuff or?
No, not directly. This is more like the programs that they do in partnership with our broader public health department or behavioral health, or even some of our nonprofit partners and organizations that have programs.
At this point, I'm just sharing sort of the trajectory of where things are headed, and when it comes to rubber hitting the road, I can't do all our transparent about.
Sorry. Thank you.
And the HR one, the federal role will affect our FQH.
There's so much right now. The world of medical is not making its numbers, right? And things are, you see these stories about different health systems that are really taking it in the line there. And our access to clinics is so important. So I haven't been able to figure out how that trickles to us, right? And so thanks. Yeah. Trying to piece the medical side and the other side together is for a layperson strange to me. So thanks.
Well, what about from, as a payer? It's one thing to talk about the overall cost of healthcare escalation. It's another thing to talk about adjusting the delivery system. And as a payer, many times you do have the power to encourage, different types of delivery, systems and access. We talk about access all the time. And I think, I'm a healthcare executive. I still sit on a membership for a fairly large healthcare institution. And what I'm challenged by is just the opportunity to deliver healthcare in new and innovative ways. We've been delivering healthcare the same way for decades, if not almost a century now. What are you seeing as a payer, if anything, that gives us encouragement that we are looking at new and innovative ways? Now, I know everybody talks about AI and its impact on healthcare. It's got to have an impact. Whether it's going to be, next week or the next year, it's going to have an impact. I think it's too early to kind of fully understand how we're going to integrate it in. But things like the utilization of midlevels, the utilization of RNs to do higher acuity assessments and diagnoses of things that, we're well beyond the days where that should be done. And access is a factor of supply and demand. We don't have the supply of medical folks at, the specialty level. It takes months to get into a specialist. Same thing with primary care. And so how do we open up access? Sometimes through ways of payers. And the reason this is so important is because the topic that we're on, our homeless, unsheltered, and house population, one of the critical things we need to have is access to healthcare. And that access question is a much bigger question. But from a payer's perspective, are you seeing anything that's encouraging about where we're headed to increase that access? I just had a presentation from a company called OnMed, and they had these healthcare boxes per se, and you go through it's a video visit, but the difference about this over a home visit is they have much of the devices required to do a visit is in this box that you normally wouldn't have at home. And the quality of the blood pressure cuff and all these things are significantly higher. And so these things are, I forget how much they cost, but a couple $100,000 a year. These are the things that, we're looking at, right now. This was in my mayoral role. We're evaluating this to see if we can deploy something like this, for folks that just don't have access. So, no, it's a long question. You have all the answers, I'm sure. So.
Oh, definitely. No, not at all. I think you're asking the right questions. I think a couple of things. I was just having conversations with some colleagues last night that, we've done a lot of innovative work over the last 5 years in Oregon, here in Portland. We've tried a lot of experiments. It's time to get real focused about which of those really worked and we want to double down on and make standard of care, and which of those were good ideas and we learned some things, but it's time to say, like, that is a lesson that we learned and we're done with that. So making some of those hard distinctive choices about the things that we have innovated that worked and what hasn't. I think there are things like we did a big, broad, open set of telehealth services during the pandemic, and that, federally that's regulated, but trying to protect and preserve the access to telehealth services for MAT and OUD, like that worked really well. It was much more cost effective, worked better for members. We saw a higher rate of people keeping on this medicine. So making sure we protect that. And then things like, I've shared a little bit about our focus on those with the opioid use disorder, a stimulant use disorder, or diagnosis of psychosis. If they are going to emergency rooms and into inpatient medical settings, let's make sure the SUD services are there and available, or the mental health services are there and available at the point of contact. It's a big question, and you're right. I think fundamentally we have to get a little more back to basics about what works, what doesn't, standardize the things that has evidence behind it, and then.
So Mindy, you'll loop back around with us when rate setting, I'm saying rate setting, that might be the wrong word, the reimbursement rate. I'm just remembering the article that ran within the last week, the 10.8, like when, is that final?
That's final.
It is final. Oh, okay. So getting specific around the financial impacts when you are ready, and then behavioral health specifically. Okay, when you're ready.
Questions for this group.
Thank you. If no other questions, you ready to move on?
Yeah, thank you. Thanks so much, Mindy. Appreciate that. It's great for all of us to have perspective on what's happening with some of our favorites. Like I'll share reports. I appreciate the conversations. All right, so next I will turn it over to
Yeah.
first.
Yeah, I'm just gonna do a quick representation of where we were with a few slides last time to ground us. If we could start the PowerPoint, and I think everybody is actually tracking this stuff pretty closely. So I'm gonna talk very quickly and just remind you that, right, we're swimming way up here in terms of key performance indicators. It's the what. What do we need to know whether we are succeeding? Below those are just tools of sub indicators, the how and the why, all the way down to the program and the contract level, where everything gets really granular with outputs and outcomes and contract agreements and those sorts of things. But we're swimming way up high up here at the systems level. And then, of course, all of those pieces are connected back to the policy and investment decisions of all of the elected bodies that are funders of this work. So at the end of the day, you want to see change and systems change, right? It's got to be funded. The work has to be funded. Next, we just shared with you our development and selection process around KPIs. Our recommendations were largely grounded in them being measurable, leveraging existing data, strategic alignment with the goals of the plan, and then of course a system-wide impact. And then next, we showed you our recommendation. We recommended 4 across the continuum, and then specific ones under inflow, outflow, and safety safety on and off the streets, which are core components of the reorganized action plan. And then after you saw that, you gave us a lot of great feedback. You gave us a directive to develop a length of time homelessness. We have done that. We have a recommendation for you. You have an associated memo in front of you that was emailed out on Wednesday. And then you told us to get going on developing recommendations for goal setting on at least 4 of them. We've gone a little bit further than that, but we will talk specifically about those 4 in response to the feedback that y'all gave us. So with that, I will, unless there's any questions, just to re-ground us, I'm just going to kick it over to Ryan and Lori to take us forward from here. I think we're good.
Great.
Go for it.
Good morning. So what we're going to cover today looks a lot like the last slide that Jillian covered, which is where we left it off after last month's meeting. So we're coming to you today to go a little deeper into proposed KPI to measure system level length of time homeless. That was one of the directions that you provided. So we're going to walk through a proposal to do that, be able to have questions and discussion on that. We had two KPIs that were sort of left as TBDs, right? It's all the acronyms, but we needed work to be able to bring you a more specific proposal on, and we've done that work. So we want to come back to you with some specific proposals around how to treat domicile unknown, thinking about deaths while folks are homeless. And then an update regarding development of a health and behavioral health focused KPI. We talked about that last month. And it said we intentionally want to wait until we've completed some other analyses before we bring some recommendations. So we're at a good stage to bring those recommendations forward today. So we'll talk about those three KPIs in more detail. And then we're going to come back around. We had promised like the easy work, if you will, is figuring out what we want to measure. The harder work is figuring out how we set goals around what we're measuring. And so you asked us to bring you some recommendations around goal setting for at least 4 of those. We'll use those to provide some in-depth detail and discussions around a general approach to setting those goals. And then we're happy to have broader conversation today about any of the other KPIs as well. You have a memo in front of you that has each of the KPIs, how we're proposing to measure them, and then also how we're proposing to set goals around them. So today isn't a decision point for you all. You don't have to it's not a vote, yes or no, we like this goal. It's really an opportunity for you to provide directional feedback to us. I like the direction you're moving in, or we have these concerns. We want you to think about these things so that we can bring you very specific goals for each of those KPIs for next month's meeting in October that you can look to adopt and recommend moving forward to City Council and the Board of County Commissioners for incorporation in the IGA. That makes sense from a process perspective. Okay. So with that, I'll turn it over to Lori to talk about the first of those 3 KPIs in detail around length of time homes.
Absolutely. So last time at the end, we had a request to find a way to track length of time homelessness on a system level. We mentioned this is not the easiest thing to do. There are a variety of reasons, including where do we start? How do we know when somebody starts becoming or experiences homelessness for the first time? And then a variety of complicating factors around, frankly, the shortcomings of our data. So with all of that, we looked into how other COCs or how other areas measure this metric as a general rule. And here are some of our recommendations. I want to start with what we're not recommending, even though it's sort of option 3 right now on this list. So there's actually 3, not 2, if you're reading closely. It seems intuitive probably that we would start with length of time on our by name list, but there's some shortcomings around that. And they've all been brought up in the past, which is often the first time of contact with our by name list is not the first time somebody is homeless. And it's an important thing to track over time as we begin to expand our by name list, because our services expand, our by name list expands, and we can kind of see how all these things are working together. But it doesn't necessarily get to the heart of the request, which is how long are people homeless? So average time from homelessness to housing is our recommendation. The details are where this is critical. The front end of that metric is the first time we have said they were homeless. So this is a self-attested homelessness data. I was homeless on this date for the first time. There's a little bit of noise in there, but that's generally considered to be the best way to do it. The end point of that is HMID. So in homelessness data, this is the point in time in which we track somebody got the keys to an intervention that led them into homelessness. It's not their first engagement with a homeless plan. It's not our first engagement with a system, like with a shelter. It is when they get the keys. It doesn't track every person, but it's a really good indicator for a small group of people, or and actually a fairly large group of people, because there's thousands of people who have HMIDs, to give a sense of how long it's taking us to get people into housing.
That's the difference between not putting length of homelessness on the by name list versus by name people telling us how long they've been homeless. I don't understand that difference.
So sometimes when people first interact with the by name list, they've been homeless for a while.
Right.
So that's the key difference.
But they couldn't just say, oh, this is my first day. I've also been homeless for 3 years.
It's the same. Oh, yeah, so I should be clear. It's the same data source. It's just rather than saying this is the first ping into our system, this is when they said they were homeless.
I don't think I'm getting the difference. Am I just?
No, I think it's, no, I think it's a data entry point. So it's the by name, if they use the by name list date, it would be when I entered that person in, as opposed to what the person told me in self-report.
Okay, thank you.
Yeah.
Sorry.
So it's not that we're not going to apply time of homelessness to the by name list.
Right.
We're not going to use the by name list origination date
Yeah.
as the factor. Okay, thank you.
So,
It did not come off the page that way and I was like, thanks for, okay,
Yeah.
thank you.
apologize. It's a. Well, I'm sorry.
On city council, we're talking about something at the third grade level yesterday. If you, somebody did. Yeah.
HMIS is overly complicated and having entered data, I can translate sometimes.
Thank you. Thank you very.
I feel much better now. Thank you.
So this data comes from our by name list, but rather than the first time we collected data, it's the first time they say they have been homeless.
Yeah.
And the only other key nuance here is we're not tracking people leaving in a variety of ways because we know with HMIT they got the keys. So we want to be really clear about that. The second one, which is recommended, is cumulative days in sheltered temporary housing and safe havens. And I know this is a little weird, but it's a good summing indicator to track because it gives a sense of how long they're in shelter and other systems before we ultimately find housing for them. And as many people have mentioned, this can be a positive thing. A certain amount of time in shelter can be make it more effective when we get them into housing. But in general, it really just gives us a sense of ideally, you don't want people in our shelter system for a very long period of time before they become housed. So you're kind of just watching that in tandem with the overall length of time homeless. And then the final one is that average median time from HMIS contact to housing. So you're watching all three. How long are people in housing? How long are people in the shelter system? And then also how long from first contact to housing. And the second two are a little more what we have control over, but they're tracked on more of a basis to see how we're doing in a granular way, whereas we're looking at the KPI. I'll stop there.
So
And-
on the HMI,
And if folks, sorry, if folks want to put their name tags up, then I'll try the next question.
Absolutely.
You're fine. Sharon, but I just like if other folks have it.
the housing move-in date, how accurately is that being entered and how consistently? And I guess another piece of that is if I house somebody with county dollars, I'm going to put that in. If I use other funds, I may not be required. So just how accurate is it on the front end?
You are correct that not every single person will put an HMID in. It's getting better and better. We've had audits that show it's really, really becoming much more accurate. If somebody is housed through a fully different program, it has nothing to do with us, and they're not entering an HMIS, they might show up as exit to housing, and that's a loose. So this is a sample of the overall population, but it still is going to give us a better idea of how long people are homeless than anything else we have on the books. And it also means that that whole question of how do you really know they exited to housing is off the table.
So can we do some really concerted education with our folks doing data entry to help them understand the importance of this? And I think have a check-in point around it. I don't think there's a ton of housing that's not getting put in there, but don't know. And so it would be just great to kind of stay up on that. Right.
And that is part of our QA effort right now. In fact, we've been sort of upping our game as far as training year over year. And we're even creating like self-training modules to make sure people go back and retrain and understand what they're supposed to do. So we have increasing faith in this particular, it's actually going back many years that it's a little inaccurate, but going forward, it looks pretty good. Could I have next slide? I also just wanted to share that this shows up on quite a few dashboards already. It looks like this, and so you would be tracking it over time in this particular way.
Any other questions? Yeah.
Could you help me understand why we define housing?
How we define housing.
Yeah, what is this? What is the for your definition of housing?
Yeah, so we have a place where they have a lease, they have keys, they have moved in, it's not, they're actually inside this metric as well. This is key is not transitional housing. We do not do transitional housing in this metric because there is an end date in which they have to move out. And so we put that in the category of shelter because in the end, it's not a permanent resolution to their home. So it would be permanent supportive housing. It would be long-term rental assistance inside a place with keys and a lease, or it would be rapid rehousing with sustained rapid rehousing.
Just flag, I'm concerned because there's some individuals that I don't know if a key is the appropriate place for them, at least immediately. If they're going to show up for a long term, and you could say that KPI, try to hit it to move them in, but that's not necessarily the appropriate place. It may not be for a long time. We don't know if that segment of population, I don't believe there's some work being done around that, but I'm concerned that we're not tracking those that may not be able to self-sustain in that. We know that that's showing up in affordable housing, massive issues associated with that. Those that are getting keys and can't necessarily take care of themselves within that housing. So I just question, how do we nuance that within our KPI and discussion?
Yeah, so I will mention, it's not a KPI here, but we do actually have multiple metrics that we track on the HSD website, you can see, which are basically housing retention. So we can see where people are at 6, 12, and 24 months. And we've actually had a pretty high rate on that, but that is one of the sub-indicators that we've called out, is also tracking how well we're keeping people housing, not just how we're getting people into housing.
And specifically for that population of folks who have some of the acute behavioral health issues, where it'll be a nice segue into the third KPI that we're going to talk about today, because we're trying to pull that nuance out.
And I would add, I think we're actually missing the housing type that you would be talking about. So we have folks that are either in PSH or they're in like state hospital, and we're missing a lot of that in between housing.
So to your point, Peter, it's like, if we're measuring keys in hands, that becomes the thing to drive, the red dot to a green dot for improvement. And that might not always be the thing you should be putting up red. Yeah. Yeah, my concern, that's that middle, or yeah, my concern is particular around that is those that are, and been unsheltered for a longer period of time. The ability to get them to a place that's safe and stabilized for a long term before they can do that. And that's one of the things that gap is just not being held. It's like the system analysis. We're trying to do the same thing and expect.
And this is where we're really trying to work on a pretty comprehensive set of indicators that can help you understand both, like, are we getting people to housing? And once they get housing, are we able to keep them stably there? So that you can kind of look at both ends of that, if you will, and make sure, if we're tilting really heavily towards one, but then we're falling off on the other, we know there's work to do in between.
And exactly, Ryan, like this is really so that we kind of have this general KPI that really helps us know like how the system is whole. To your point, and we've had lots of conversations about this. I think the point is, even if someone is, coming out of the state hospital and they need like an interim service or type of housing or an additional place to go, that's not necessarily like days to a place. We don't want to be counting that here in this metric, because that is not the permanent place where they're going to be. But ultimately, like, we have to be looking at the system, and I think, using those two together, as you were describing, Ryan, helps to give that picture. Although I think we're all very well aware of the need for that.
We're gonna get to Peter's point on the behavior.
Do we? And make sure I'm not missing or losing track of it, but do we have a metric for that? Because it is the storytelling, right? It's the whole continuum. So when we're going back to sort of revise or look at what's working, what's not, or where we have to sort of expend our energies, are we capturing data for those folks that are going to have a longer stretch of being able to get keys in hands and in the door, like where they sort of sit and where they're sort of being held in the continuum in terms of, I know we just said we're not tracking transitional, but that is essentially what that is, right? Like, where are these folks, like, coming from the state hospital? They're in these temporary places. How long are those individuals sitting in that space? And what's keeping them there? What barriers, are there barriers, pieces that are saying why we're not able to get keys in hand to those folks? I think, like, I'm not sure if we're capturing that, because I think it's a big piece of the story. And then again, same as to when someone gets those keys, and if they fail out of that housing, why are they failing out that housing? Like, to me, that's critical information to know. Like, where do we need to plug in supports to ensure that people get to that path, or why are they languishing maybe in this middle transitional space or something like that too?
Lori, can you clarify again? Transitional housing, an exit to transitional housing is just, it's not in this.
Yeah.
It's not.
I'm just wondering if we're capturing it though. Like, it is somewhere. Is it somewhere in our storytelling, in our data collection?
So it's not necessarily in a KPI, but I don't want to spoil what we're about to talk about in the beginning. It's actually a little bit of what we're about to get at, which is tracking some interventions around who we know are going to have a harder time PSH. But then also there are a variety of others, but these are just the KPIs. We do evaluations that are a little more in depth with a little more storytelling, as you were describing. For example, right now we're doing a Pathways project and we're looking at what are sort of the stories behind what worked and what didn't. So we track that. And then I also feel like there was this wealth of information in the data that you just shared around what's happening in transitional housing that we can look into. So some of the follow-ups on that data are not necessarily what we're sharing today, but what we're planning to look into as sort of fodder for what do we do about those particular people.
I was just gonna add, I know today we're talking about high level KPIs, but I appreciate and hear how you guys are balancing kind of inserting key elements of the issue that we're talking about into some of them. And I think given the amount of conversation we've had and the known issue, it might make sense to have a real clear kind of subpopulation focus on that group, that where we don't have to look at like it's a sub indicator of this and what's the relationship to this part. So just like as we think about constructing our final list, how might we pay attention to that subpopulation across all of it?
Yeah, and that's actually really helpful too, to remember, we didn't mention this up top. As we're constructing each of these key performance indicators, one of the criteria that we were looking at, that Lori and her team especially were looking carefully at, is every one of these are indicators that we can disaggregate pretty significantly. So we can understand important racial equity impacts associated with that. We can think about other priority populations that we want to understand. So we can both look at how is the system functioning as a whole and how is that system functioning for individual groups of people within that.
Okay. Good. Oh, sorry.
I just want to, this is definitely a parking lot item, but I think we have to talk about what Peter raised, because I keep hearing this, folks are too acute for different levels of care that we have, and that shouldn't be the case for PSH. And so I want us to understand what is the actual S happening in our PSH so that people should not be falling out of PSH at the rates that it sounds like they are. So parking lot for sure, but just wanted to raise it since that was brought up.
Suggest something, Chair, if you don't mind. Do we want to just jump to behavioral health and then slide up and down? So we're gonna skip some slides and go to the metric. This metric is pulled in this data set from Health Share. It pulls in a systems of care table where we are active conversations and problem solving around this slice of folks.
So I'm going to take the commissioner's question out of the parking lot and to say, you all had asked us, as did our community advisory committee, I should point out, our community advisory committee, the very first quarterly report that we put together said, I think you're really missing some important stuff about the acuity of people that we're serving in our system right now. I wish you had KPIs. I wish you had data that would help us understand that and think about how to respond to this system. So, their frontline expertise called this out very, very clearly, very early on. You all have identified the importance of this as well. So we intentionally were waiting to try to bring a proposal forward on a KPI because Health Share and the Homeless Services Department have really recently entered into a data sharing agreement that allows us to combine our HMIS data, so service utilization data, if you will, on the homeless services side, with Medicaid claims data. So we're able to look at the healthcare utilization side. I'll just finish the initial analysis like 2 weeks ago.
7 minutes.
Yeah, it is like brand new, and it's actually really exciting. I know some folks have had briefings already. I expect we'll bring that back to this full group at some point soon. But and Mindy, I encourage you to hop in with some highlights. But essentially, the analysis is looking at a subgroup of folks that are served at Health Share who have high acuity behavioral health conditions. So in particular, looking at folks with opioid use disorder, stimulant use disorder, and or psychosis. So, and there's this pretty significant, some folks have 2 or more of those. And then overlaps that data with our HMIS data to try to understand where are we seeing those folks in that high acuity behavioral health cohort show up in our homeless services system. If you'll go to the next slide, so I don't even know what slide is up. There are about 9,000 folks that fall into that high acuity behavioral health cohort who also showed up in our homeless services system. Pretty significant overlap. First off, about 70% of the people who are served in our homeless services systems are health share members. So it's like a very large number of the people who are receiving homeless services are receiving their health care through health share specifically. But there were about 9,000 of those folks who fell into that high acuity behavioral health cohort who also who received services in our homeless service system. One of the, and I think significantly for how we came to this particular KPI, if you look at the folks who are served in shelter, it's a little more than half of people who are served in shelter fall into that high acuity behavioral health cohort. And a little more than half of the folks served in permanent supportive housing also fall into that high acuity behavioral health cohort. The highest actually was in transitional housing, but that's not surprising because most of our transitional housing is serving folks in recovery. So very specifically, so the overlap wasn't. One of the pieces that came out of all of this data analysis, though, was if you look at people who are served in permanent housing, so permanent supportive housing or rapid rehousing, the folks in that higher acuity behavioral health cohort were leaving that housing to homelessness, returning to homelessness at about twice the rate that folks who weren't in that high acuity cohort were returning to homelessness. It's about 9% versus 5% respectively. So still, many people in that high acuity behavioral health cohort are still very successful in their housing. I want to emphasize that, but they are leaving that housing to homelessness at about twice the rate. So really drilling in on that as a system level indicator for how well are these folks that have those high acuity behavioral health conditions served in our services and housing. We're recommending a key performance indicator that effectively says, we're going to track over time that those folks who are in that high acuity behavioral health cohort are not returning to homelessness at a greater rate than anybody else. So that's the proposal in a nutshell. We have some follow-up work to do because this initial analysis was a backward-looking analysis. So we looked at who we served over the last 2 years, not who are we serving today. So we need to do a quick true up to look at who's in our systems today. And then we can give you a good baseline to finalize that if that feels directionally correct to you all. So questions?
So thank you for that. And I just love that, like the topic that everyone is really voicing concern about is something that you all are thinking about and addressing and bringing forward. So thank you for that. In looking at this, I just was saying for this purpose, permanent housing includes rapid rehousing, permanent support housing, and long-term health and business services. It's the rapid rehousing piece that gives me a little bit of pause because I know that there have been instances where people are assigned rapid rehousing because that is the resource that we have to put somebody in housing, but that may not be sufficient for what they need in terms of the other services or other, case management, or we know rapid rehousing is at 2 years. So I just want to, I think that we do use that and it is getting somebody into housing in a way. So I do want that track, but I also want to make sure that we have line of sight into how folks are doing who have rapid rehousing and making sure, because ultimately we want to be matching the right resource with the right person, even though sometimes we know we don't have enough resources in all the areas now too. So have you guys talked about that or what is that?
Not when the analysis came out, and one of the things we talked about was wanting to dive a little deeper into rapid rehousing to the high acuity cohort. Another thought of mine, which is that sometimes it's not necessarily the PSH, they're needing some other kind of wraparound services that might move them towards stability without having to even get into PSH, or it might be a good way to identify people who should have done PSH and make sure that they're on our list. One thing to know is that people in rapid rehousing can still be in coordinated entry and waiting for PSH. So it would be useful to know what's going on in that cohort and also what we mean by vulnerability. I mean, what are the dimensions of that so that if they need healthcare and meanwhile we can. So we had like a list of many things we should follow up on the second we saw this data, and that was one of them.
Can you be looking at the data disaggregated by that resource so that we actually are tracking if there's a disparate, there might be further disparities between the type of subsidy they're receiving? What is long-term housing placements with services? This like random new phrase that is everywhere. What is that? If it's not PSH, if it's not a long-term voucher, what are we talking about?
It's really mostly PSH, to be honest, but there's a smattering of regional long-term rental assistance with services attached to it. And there's regional long-term rental assistance with less, as well. So we wanted to make sure we were capturing anything, including some of the things you were describing, which is sometimes people are placed in other programs. We still count that as long-term housing with assistance if it's any kind of program. But honestly, the majority of it is permanent supportive housing.
I hate random new definitions.
Looking for something.
Or local long-term rent assistance vouchers, like that's also a thing.
So you feeling good about this direction? There's a couple of steps we want to work with HealthShare to make sure we got this right and just on the data side. And then just so folks are aware, the difference between that 9% and 5%, it's 200-ish people.
Yeah.
So we're very going to focus in and pilot some stuff for those folks, this small slice of PSH folks who are having challenges.
I think to Laura's earlier point,
This thing is.
oh, sorry.
This is a just a quick question, and then you guys probably are thinking, but are we able to look back and see and disaggregate to the place where you're able to see where are the PSH or the services that are working so that we can be focused on high quality? I mean, not every service or service provider or property is having that. And then equally, where are the places that are having the biggest challenges so that management or the county can go in and help that with better practices? Is that something that you all can look at or just?
Yes. So what you're not seeing here, because it's not a KPI, but it is a really critical tool, is this amazing contract monitoring dashboard that we're slowly creating. What we're able to do is go in per contract and see all of the outcomes and costs. And that is a tool that our contract and program managers can use to figure out what's going wrong, what's going right, and work with them.
And I just wanted to add, but I really love, oops, sorry.
I'll put mine up.
What I really love about this is here, I've heard you say this before, the really clear connection to an action that we can take. We know now the scope of a population, we can understand pretty quickly who is engaged in behavioral health services and who isn't, and be proactive at trying to make sure that they're connected to places that serve them. And that will move this measure. So I really appreciate the very clear action oriented connection.
I think it was Councilor Zimmerman and Commissioner Simpson.
Thanks. I'm feeling generally like this is going in the right direction, like segmenting out. I guess something I'm more and more often coming through a conversation. It'll be from an ED or president of an organization who has housed people and then comes back and says deeply inappropriate for that person to have been in my home, right? Because then they go unsupported, and then there's catastrophic situations that happen that then they are feeling the pressure from the larger system to say, yes, I can take a person, and not sure about the politics or the organizational kind of relationship stuff to be able to say that didn't work out last time and I don't want to be doing that again, because now I'm putting not just that unit at risk, but other units at risk. And this is starting to really land with me, and I'm trying to make sure that we are able to acknowledge that, because part of my whole thing here, it goes back to like the way I approach shelters and neighborhoods is the value proposition with those who are taking on a heavy burden at times. They can't be left to Well, I think we all get to the point. And so I guess, do we think that this, that 200 or folks that are deeply in need of housing as it is supported housing, is the supported part is actually a more important word, actually. Um, This will help us segment out these populations. I think segmenting is a good word. I think this, it's really important that we talk about what is the thing. I talked about this last time in this meeting. What is the thing? If we had only one choice for every person by name, like this is the most important thing that they're challenged with. This helps us get better at that so that we have providers, housing providers coming to us less often saying, I'm not sure if I would consider a client from this group anymore. Okay. We think this will help with us at this, and I'm mostly seeing nods. Okay.
Yeah, big yes.
I think just the energy around that is telling me something. I think there are a lot of folks in the community who would probably be appreciative if we were, as a collective group, acknowledging this challenge far more outwardly instead of saying just random terms of PA said that, whatever I'm saying, covers everything. Or, you're exasperating the problems or exaggerating is probably a better word. But I feel like that's being seen here because I think people are really trying to lean in and then highly unequipped to deal with some of the most challenging situations that any person could go through. I'm worried that partners are going to walk away. I know some who were not sure that they really want to stay in the business, if you will. And that to me is that would be a critical error. I think just being on the same team or at least indicating a struggle or that we acknowledge a struggle goes a long way with, we'll hear you when you come and say, you need somebody assigned to that building or to that person or to that floor to make it a successful model instead of, just putting people in all the time. So I'm feeling good about this. And I hear that we're at on it. Thanks.
And just to react to it a little bit, there are two parallel efforts that I think of that are going on under the big umbrella of APAP in terms of these partnerships between our housing providers and our health systems. So one of them gets very directly at some of the pain points that you're talking about, which is looking at ways to pilot the movement of people from inpatient care to permanent supportive housing. So making sure folks that we've invested a lot of care in to help them get stable have access to housing that can keep them stable. So we're working really actively on that. This KPI speaks most significantly to the other parallel piece, which is of those folks who we've helped into, especially permanent supportive housing, how are we making sure we're connecting those stabilizing healthcare resources to those folks in the housing so that they can be successful and there's less pressure on the housing providers? So we're trying to get it at sort of both ends at the front door and then once folks are in, making sure that they have those continued connections. It's been, I've done this for a while. I often am pretty jaded, but I have like a lot of hope around some of the partnerships that are developing.
Just relatedly on that, when we say permanent supportive housing, I can imagine where a person's level of support at one point in their life, maybe in the beginning of their housing, is more intense as they grow, as they work through things. The permanent part is the housing part. The less permanent part is the type of support. But what I don't understand right now, I'm hoping is the system set up so that building A is the most intensive type of support. And then building B and building C are progressions to less levels of intensive support. It's more that you could have a variety of folks in a building with different levels of support, but the permanent word is about the housing.
Yep.
And okay,
Yes.
thanks.
So, Commissioner Singleton. Oh, are you open, Mindy, or is that old?
Yes, but I was first.
Okay.
I think Counselor Zimmerman, something you're getting to is also, the services should ebb and flow. I think we also have to address, which isn't a homeless services issue, but our outpatient clinic model.
Yep.
So ideally, I would transition a client to outpatient, but if they miss a certain number of appointments and get closed and start to decompensate, that's a problem we have to solve for, because that shouldn't just happen. They should still be able to get services. So I think that's another of the healthcare components to talk about. I also wanted to just uplift, I heard Laura asking about some qualitative data. And I think because it's such a small cohort, it would be really valuable to ask some of the questions of the why and the what happened, and digging more into some of that qualitative data that we can't pull out of HMIS. So I would ask that that be a part of this understanding. I know your team's not like at lack of work, but it would be really helpful to have some more of that. And then I think the piece I don't want to lose is, because we're digging into this work, I would really like for us to be thinking about what an advocacy agenda is at the state. We have got to find ways to get to that missing supportive housing. It can't just be secure residential, state hospital, or nothing. And I think regionally, if we're able to come together and advocate in the state, we have a much better chance than how it's kind of happened to date. And then I think lastly, I would say, I do think there's a wider assessment of retention services that is needed. We don't fund every organization the same. And so I've worked at agencies where I, as a solo person, had 60 people I had to provide retention services to. So they got less on-site support. And then I've also worked at organizations where the caseload was much smaller. And so each person got seen every week by that retention worker. And I think we've got to figure out how to right size those investments and those contracts.
So just a couple of things that I wanted to bring up. First of all, I really appreciate this conversation. And I think people are bringing forth really important things for our consideration as the SOC, but also for staff. Two things I want to say. So I've had a chance to see the HealthShare HSD data work, and it's really amazing. And I'm so glad that this is coming out of it. I do want to point out though that there's only 70% of that population that are HealthShare folks. So as we're doing this work, I'm wondering about that other 30% of the population that isn't, and how we are going to be identifying them and bringing them into this cohort if they indeed fall into that. So I want to figure out, like, are there ways when somebody is identified who isn't necessarily part of that first 200 that is also, should health share, that there's pathways to them so that they can be included in this. And then, or if it's like, Commissioner Zimmerman or Counselor Zimmerman, that it said about, like if we hear from a housing provider that a person is, causing some issues or not being successful in that housing because they do we have a way to connect that person or add that person to this? So that we are making sure that we're being responsive in the work that we're doing to really, try to focus our attention on this, which I think will still be a small cohort, but may look a little bit bigger than 200. So that was the first thing. And then I think like this whole conversation, Commissioner Singleton, I appreciate you talking about let's have this as a state, let's come together of what's actually needed to in terms of resources to help this population be supported. And I think we absolutely need to do that at the state level, but it's also important, I think, for all of us who have control over local budgets of figuring out, okay, what can we do, or what are our parts of this system that we have, that we are in charge of in our governments, and how can what dollars should we be allocating to these things as we're developing our budgets for the next year. So I also want to thank those of us who are elected at the state for thinking about that as well. Okay, Mindy. Yeah, last word. We'll see.
I just to add to your list, Ryan, I really appreciated it. But one part I heard Counselor Zimmerman talk about, and I've heard from our housing providers, is how we get smarter about how we match people to when they come in for services. So not just fixing it on the transition in, or figuring out what they need when they're placed, but how do we get smarter about matching to the right PSH service?
I think one thing we actually called out in our long list now of things we want to look into is looking at the coordinated entry list with all the behavioral information to try to figure out what the picture are for experiencing, that. I also feel like we're getting better in the relational stage, because we've been in the last year of cross-sectional case conferencing and trying to figure out how to share data in the moment around what's happening clinically. What's happening in the PSH unit has helped us understand how do we get clinical information in the moment that we can't get in HMIS. So I don't feel like we're starting at ground zero here with how we're going to wrap around this, probably more than 200 people to try to figure out what's going on.
If we have other PPS to look at, so anything else on this before we move on?
And by way of time check, we said figuring out what the KPIs are is the easy work and figuring out how to set goals is the hard work. We're still on the KPIs. We're not yet to the goals, and we've got about a half hour to go. So there will be opportunity to continue discussing. And so I want to hop back, if we could, to the slide 18. So you all had, we have talked broadly in both our Community Advisory Committee and Implementation Committee, as well as at this table, about a key performance indicator that could help us get at concepts of safety. So we talk about inflow, outflow, safety on and off the streets, right? And we know that one of the most extreme indicators of a lack of safety is when people are dying while they're experiencing homelessness. So the specific ask was that we look at the domicile unknown report that the health department issues every year and look at that as a potential source for a KPI. So just to give you and so we did a bunch of, that was one of those where we said, TBD, let us do some work on that and come back to you with a recommendation. So this is the update on that. So just to give you a little more background on the domicile unknown report, it actually comes from two sources of data. The first and longest running is the medical examiner data. So the county medical examiner notes anytime. So the county medical examiner does not certify all deaths that occur. In particular, they focus on what they would call medically unattended deaths. So if somebody's not in the hospital or under a physician's care when they die, the medical examiner is usually the one investigating the cause of death and certifying that cause of death. They also work particularly with folks who die of unintentional injury, violence. Overdose is one that often shows up there. This is a long-running partnership with the medical examiner of Multnomah County. It's a little more than a decade old, to identify when those folks who the medical examiner is working with, when they believe that they are homeless, when they die, they'll mark them. There's a checkbox that says domicile unknown. That's where the name of the report comes from. So we have that data going back quite a while. And then the report is also newly fed by the state legislature required starting in 2022 that any death certificates, so those are filled out. If somebody dies in the hospital, it's filled out by the attending physician. Any death certificate has a field now that indicates domicile unknown. What we hear from the health department is that that data set coming out of all of our death certificates is pretty incomplete. It's still new. Everybody's learning how to use it. They may or may not know if someone was experiencing homelessness when they came into the hospital. So it's adding to that data, but it's believed already, to be significantly incomplete. So I wanted to share that as context. So we've had some pretty significant discussions, both with Implementation Committee and with our Community Advisory Committee, to try to give us some advice around how might we use these data. And that'll go to these recommendations. Both of those committees, in looking at it, the primary concern with using this data set as a key performance indicator is that it really lags. So the health department produces a report in December that's telling us who died through all of the prior years. So December 2005 will tell us who died in 2004. So in any given report, you're seeing who died between a year and 2 years ago. So it's difficult. It's really, really helpful for understanding long-term trends, but it's not particularly helpful for what's understanding today. It's helpful for understanding what happened a year to 2 years ago. So their and believe me, like both of these committees in looking at this, said this is one of the most important things we can understand. So, and they said, we don't think this is a particularly good data source to understand it. Their recommendation was that this is better addressed as a set of action items within the plan. So looking backward, what can we know from domicile unknown about primary causes of death? And in general, what you see is overdose, traffic safety and gun violence are significant drivers under that report. So if that's what we understand about some of those primary causes of death, let's organize some action around each of those specifically. How can we work really carefully with the gun violence prevention programs at the city of Portland, at city of Gresham, to think about how to take models that have been extremely effective in working particularly with Black youth and start to apply that to folks experiencing homelessness. And then as we're pursuing those action-related pieces, we can look then for more real-time data sources that might be able to inform how is the system moving. So that's the recommendation that came out of that conversation. Opportunity to talk through that.
I think for the enemy, what we're trying to get at right now. I get a report every Monday about the homicides, the time homicides on the street are representing 50% of all homicides now. I think we should provide data to us with the caveat, this is not confirmed. And at least it gives us a prognostication as opposed to a diagnostic approach to it, Ryan. And from a public safety standpoint, I'm sure Councilor Zimmerman and I would support you in trying to get you the data.
Yep.
I think we're looking for trends. I don't think we're looking for actual names. We just want to know what's going on the street. Are we having a material impact on the changes in the systems we're bringing forward? So I applaud you. I would go back to the medical examiner and ask for preliminary reports. Again, we're not looking for perfect. We're not looking for names. We're looking for directions of the information so we can tell if we're having a meaningful impact.
Well, that's the strategies piece. Will you go there?
Yeah, exactly. I was gonna say that's entirely consistent with what each of the committees is recommending. Yeah.
We're in a crisis.
Yes. Stephanie Howard weighed in heavily, and she's got an existing relationship, Mayor Stovall, with your gun violence prevention, employee at the city of Gresham. We can pull in county public to actually develop some strategies around gun violence among the homeless community in particular. But we need to also identify the strategies. Even if we had perfect data right now that was given to us in real time, we still have to define what we're going to do.
Yeah. And we can then extrapolate or extrapolate, but go beyond it. And we know when we have generally hypothermia, deaths, and then living conditions. And we know when addiction and or overdoses occur on the street. We have, and then people dying in the shelters. We have that number right there. So I think we could bring a bunch of these disparate parts together by just bringing our systems together.
As always, it feels important to note that the life expectancy of people experiencing homelessness is 30 years lower than the rest of this community. So it always has been a lot, which is, challenging as all have for our staff. I mean, spend so much time. We used to actually stay all the time, at least they died inside.
That's right. Yeah.
Councilor Zimmerman.
Thanks. I started working in the county in 2007. So we're in politics in the county in 2013. I remember the year when we surpassed, I think it was 80 domicile. And that was a big deal on a big day. And we're now into the hundreds and hundreds. So I value the tracking, right? I think if I were to put myself back in younger, skinnier Eric days, I was thinking that report was talking about exposure in a lot of ways. And seeing now what these numbers look like and the change that we've seen with not just exposure, but also now how the type of drugs that we're experiencing today is affecting them also at a higher rate. Folks on the street is, while it's lagged, and I appreciate the lag, it is still remains for me a really important indicator of just how this is not normal, right? If we just go a decade ago in terms of what the numbers are to today, that's not gradual growth. Gradual growth would be terrible. This is spiky growth. And that's been, I think, a helpful thing for me. And also to evaluate what are the things that are contributing to the deaths I think it's somewhat related, but just this week, the city council reaffirmed its 10-year Vision Zero commitment, right, about traffic fatalities in our community. And I was able to get the council to add an amendment to that, which is for the first time, we're going to focus on homeless pedestrian deaths, because that's been an area that Vision Zero has not specifically addressed, but 50% of the pedestrian deaths that exist on our streets are homeless folks, right? And they represent less than 2% of the population, right? So there's a pretty overrepresentation piece. So the deaths, this report, it helps us make decisions, helps us be more informed. I'll take late data or no data any day of the week, right? And just highlight just how damn non-normal this spike over the last 5 to 10 years has been. It's just been, these are really big numbers. So I appreciate it.
Thank you. I really appreciate the work on this. Again, the one question I have is, does it make sense to be looking for the same data across the entire system? So also, overdose, suicide, or unusual deaths in the system, so shelter or PSH, because again, like the system would show up if we have significant, and there needs to be preventions or other things that are happening. And just knowing that we don't know what we can.
And this is a piece where we can do some digging, but my recollection is the medical examiner especially will use proxies. Like, for instance, if the person's address is one of our shelters, they'll be counted within that domicile and known count. I don't know how comprehensive that is, though, in the broader systemic context. So I appreciate that support.
The relationship between the county medical examiner and this report was really tight and has been a, longstanding thing for the last more than 10 years. It's I think, to Ryan's, it's the state and some of the information that we get from the state for those, like if it's in a hospital or something like that, that's where the data gets fuzzier. But it is, because that had come up before, like if you're in a shelter, does that stuff? And it does. Or at least it has tradition.
So I want to summarize, this is just for now. Like, we got to do some work. Mayor, you made great points about other data sources. I know Stephanie Howard knows all this, like it's literally right here on her head. So we're going to continue to work this. We just can't legitimately develop a KPI right now for this. But it's important to everybody. Everybody's in agreement. We want to get there. So does that feel fine to folks? We report, okay.
Can you bring it back? Can you come back in like the next couple of months to, yes. I'm gonna get the next couple of months and let us know. It's like a way to get at this or what this is gonna look like as we're talking about it.
And we should also call out, just starting into this conversation has built some really strong connections, both with the public safety folks on the city side, as well as with our public health folks that are tracking more of the epidemiology of accidental deaths, that kind of work. So it's even just asking the question, make system connections happen that hadn't existed before. So, okay, so let's transition into the goal setting conversations. I want to, let's see, so this will get us to slide 25, and I'll transition it over to Lori to talk about some of the general approaches that we're offering and recommending around setting goals associated with this. Again, we're not asking you to vote on, yes, this is the right goal today. We're really looking for directional feedback. Like, we think this is the right approach, or we think we need a different approach, and let's talk about it.
My only addendum to that, Ryan, is that if there is consensus and there is a desire for a vote to be very clear about what it's moving, give that thumbs up. We absolutely welcome that.
So I'm just going to talk a little bit about how we ended up developing a recommendation for each of these and what some of the guiding principles are. So first, I want to start with our recommendations that each benchmark be strategic, not aspirational. It doesn't mean that we can't strive high, but it means that something should be attached to something that is funded, that is strategized, and that is a policy or program that we are planning to support. The goals should be SMART, meaning they're specific, they're measurable, they're achievable, they're relevant, and they're time bound. And again, mentioning grounded and established agreed upon funded strategies. Also, we're asking that people textualize recommendations and the recent financial implications that we currently have. And what I mean by that is that we can't fund everything everywhere all the time. So we are going to have to, if we set a goal, include in that goal intention to focus on the strategies that will affect that goal. I will mention one final thing, which is that all of these benchmarks will be monitored to ensure equitable access and outcomes. That means that we can not just disaggregate the data, but that we should be looking at the data to see if we're seeing disproportionality in any of the goals that we're looking at. So this is a key grounding factor that will be looked at through there. It is something that we've been doing inside the joint office as well, or the Home Services Department, but we would be able to extrapolate to the population at large. So moving along. So there are 4 ways we're going to approach these. It's actually 3, but with 4 different reasons behind them. So the first option, when you're looking at a KPI, is set no benchmark. We're going to watch it, we're going to see what's happening, but we're going to indicate what the positive direction would be. Should it move up or should it move down? But we are not necessarily going to set a particular benchmark. We're not going to say it should get to A from B or B from A. So this is because KPIs have multiple drivers, many unknown factors. And so it's really hard to say where this is going to go without massive modeling. So we're just going to keep an eye on it and see where it's going to go. Option 2 is to set no benchmark because it's a really key indicator to know where things are going, but we don't have a particular goal or strategy. It's not attached to the HREP. So setting a benchmark is not really ours to do. The option 3 is a ratio benchmark. And usually that happens when something happens in relationship to something else, meaning the number of homeless people might affect how many shelter beds you're going to need. So it's a ratio to an overall metric. And so they kind of pivot with each other. And then finally, they're setting a number goal. So this is when we know that production resources will specifically impact an outcome. We are going to house this many people. So we are going to say this is how many people we expect to house.
Can you give an example of option 3?
Option 3, we're about to see. So there's actually each of the ones that we picked out has something in this menu. And it's a little wonky. So it's much easier to do with a specific example.
And again, you have in front of you a detailed memo with all of the proposed KPIs and what the recommended goal setting approach is. So you can reference that as we talk, and it's called out by that option 1, 2, 3, 4. So
next slide.
Here's one document. I see people shuffling paper. Sorry, it's this document. It's the updated definition document.
We have provided you with the definitions document. It has not just the definitions, but recommended direction on every single one of the benchmarks, even though we're only talking about 4 today. This is partly because we're pushing through trying to figure out what was the right strategy for each. We realized that we should really just go through and figure out which categories each of these KPIs fit into. But I'll start with number 1, which is people experiencing homelessness. This is a very complicated metric. It has to do with how many people are becoming homeless, how many people are being housed, the economy, things like, I don't know, a pandemic can really affect how many people are homeless. So we obviously want to indicate what the positive direction is. I think everybody knows what that direction should be, and it was down. But we are not necessarily saying this number of people will be homeless in a year or 2 years or 3 years. An alternative to that is saying how much of a net reduction you want to see in percentage. But in general, you're not saying we are going to be reducing homelessness by 500 people, 10,000 people, whatever you're looking at. I will give an example of the next one and then I'll open it up for questions just because of the chair's question a moment ago. So with people experiencing unsheltered homelessness, this is where we would expect you should have a ratio, which is over 3 years, reduce the number of population of people who are going to be unsheltered from current rate, 47%, to another percentage. The reason we lean on a percentage here is 1, having an absolute number doesn't make sense since the denominator can change. Secondly, it really tethers us to a strategy. How many people do we think should be sheltered of the percentage of people are sheltered? And so if you reduce the number of homelessness overall, that other number will pivot up. So there's a couple strategies you can employ there, but in the end, you're really saying in a world where there's limited resources and you're not looking to shelter 100% of people all the time because you can't do that and house people, what are we looking to do? So I will pause there and get feedback.
Then we have two other examples that we can offer of some of the other strategies on the next slide as well.
Why don't we go through those then? Yeah.
Next slide. Yeah, people who have exited homelessness to housing. This is where we would set a number goal. We know how many housing units for how much PSH, how much rapid rehousing we're likely to put in the budget. Our goals should match that. Pure and simple. An inventory of affordable housing units, perks from low income. This is also where we would set a number goal because we can program that goal and then we can follow that programming.
Want to hand it off to Helmy right here?
I'd be happy to come up to the table. Thank you. Yeah. You can go over here.
Great. Grab it, Jeff. Right.
Daydreaming. So. Is the question, how we set a number goal? So. The amount of housing, that is needed is a function of, that we want to set a target for is a function of both what's needed and what can we deliver. And the current, let me just orient myself to my notes because I really evaluated this. So there's been a lot of discussion around permanent supportive housing and 30% of AMI units, and I wanted to provide a little bit of context for that. A 30% of AMI unit is basically an apartment that for one person, the rent is $652 a month in today's market. So that's the maximum rent for a unit at 30% of the median. The difference between 30% AMI unit and a permanent supportive housing unit is that a permanent supportive housing unit has services attached, but it's typically that rent level, that low rent level. And we have both of those in our system. We currently have in the city of Portland portfolio, we have 3,329 units at 30% of AMI. We have within that portfolio 2,238 PSH units. And we have 361 that are in the pipeline of development. So that gives you some sense of the numbers that we have. If you think about the total number of people who are experiencing homelessness in the county, there's 16,000. So, the number of available units is far lower than the number of people experiencing homelessness. And the target, we don't have a target set for how much we need. I think we have to go through an exercise of really making decisions about what percentage of folks will be exiting into different forms of housing. So I think you don't need 100% of folks exiting into 30% of AMI units, but you probably need more than 3,000 units to serve the current 16,000, which is kind of a constantly renewing number at this point in time. So I think from our perspective, that we're taking let me actually say we have 300 and I mentioned that we had 361 units in the pipeline. Our funding, our capital funding for both the Metro bond and the Portland housing bond are fully committed. So I don't anticipate we're going to have any more than 361 permanent supportive housing units after these will be completed in 2027. After that, I don't see us doing a lot of new units, the current method that we're using, which is using tax credits. I think the pipeline is going to move to a trickle unless we have another strategy for capital development. And so at the moment, I was doing some estimating that, on our current scenario,
well, I was looking at what was the estimated need. So the Bureau of Planning and Sustainability, working with the state, estimates need of housing by population, by income. It's related to the homeless population, but it's actually factors in a lot of other things. And they have three estimates. They will estimate the 20-year estimated need. On the low end, the 20-year estimated need is 6,500 units at 30% of median. On the high end, the 20-year estimate is 24,000 units. So there's a pretty broad estimate, and 24,000. So and the middle range is 13,000. And I think at the moment, they're still doing this analysis, but at the moment, Bureau of Planning and Sustainability is saying they're probably going to move towards the middle target, which would be 13,000 units over 20 years, which if we said, okay, we're going to set a target of 13,000 units over 20 years, and we set that target, that means we would be producing 650 units every year of 30% of AMI or supportive housing units, 650 per year, using our current methodology of funding. That would require a local subsidy of, let's see, it's a pretty high number. Our estimated cost is $91 million of the local subsidy. If we did it if we were able to somehow drive costs down and do half the amount, it's a local subsidy of $45 million a year to hit that target, to hit the middle target. So this is just really at the moment, these are really conceptual. I can certainly dig in deeper. The conversations so in terms of setting targets, I think we are, we really have to have a few things. The first thing we want to do is have a much stronger, better inventory of housing across the entire county, because right now the only data we have is the city data. We're missing some units. So we're going to start a data working group with the city and with the county and with Metro to get a better handle on how many units are in this is all the regulated subsidized housing. The second thing is working closely with the mayor on the vacancies, really having a much clearer handle on vacancies and what's out there, what the capacity is. And then you can create 30% of AMI units by putting rent subsidies into higher income units. So we can also we have a supply of units that are at 60% of the median, which means, in terms of rent, we have units that the rent for a 60% of the median unit is about $1,300 a month for a single person. And you can use a rent subsidy to buy down those rents. So we might be able through a rent subsidy strategy to buy down existing supply of our 60% units. All this to say is, one is get the inventory accurate. So we're all working off of the same numbers across the whole system. Two is evaluate the exit strategies from shelter, because there is, reunification, there's a variety of different strategies, and see what our targets, it'll help us understand our targets for other strategies, and then really look at what the capital need would be to deliver more deeply affordable units. I think it's super helpful, the conversation around permanent supportive housing, because the permanent supportive housing units should be for those with the highest acuity that need the most support. And having a really clear understanding of the demand for that helps us figure out how to encourage the housing providers to move people that are lower acuity out of the PSH units, freeing up the units that have more services attached to them. So I think we can get to a very clear understanding of the housing supply that we have. We can set forth some goals based on current available capital. We can also set forth a goal on, or a conversation around future capital demand to continue to add to the supplies. And do you think we're undersupplied at the low end? And then our department really working hard to figure out how to do it more cost effectively. Can we do it with can we buy existing apartments and start on turnover, pushing those units down to a lower rent? Hopefully that helps.
So Helen, can you just boil it down to what you think your recommended approach on this for the group is right now?
Well, I think the approach that's defined here, inventory of affordable housing units per 100 extremely low income households. I think that's a good approach, is to benchmark it based on the number of people. But I don't think at this point we have a number based on, like, should we be, what we don't know is, are we recommending a supply that is 50% of 100 people, like 50 people, or is it 20 people? How many housing units do we think we need per 100 homeless people? So, if we know today there are 16,000 folks, and actually, let me even go down. There's 4,000, according to the numbers that I was looking at, there were about 48, 55 shelter. We wanted to match the shelter exit strategy. We could be targeting our supply based on the number of shelter folks that we're trying to move out of shelter. But I don't have a recommendation today on the number. I think this is going to warrant more dialogue. I think the approach is correct per 100. And I can break down for you, not verbally, I can actually maybe in your next meeting provide you a chart that will help you evaluate what could be an appropriate target. It's all about capital. It's all about, can we, where's the money to deliver on these? And we're fully committed with our capital today. We don't have additional Metro bond or Portland housing bond. We have a little bit of money, but we're going to be, yeah. So
I want a reaction, but I don't know who was first here.
I know, yeah. Thank you. I mean, I will just say, just to start off, like, it feels like there needs to be, like, the housing people from different housing organizations need to get together and do some work and then come back with something more concrete that we can work at. So I just want to.
For sure.
Yeah. Okay, so I have Ivory, Commissioner Singleton, Commissioner Zimmerman.
Yeah, I just wanted to say, Helmy, thank you for, I know that you recently you're pulling together a work group to dig deeper into the actual inventory of what these units look like. And that's more so like, what units do we currently have that are tied to a deed restriction of some sort to ensure that they remain 30%. I know that we have those units that are funded by Portland, by the bond for the city of Portland and also Metro Bond. And then we're bringing OHCS into the dialogue to capture those units that are privately owned.
Or
Subsidized, yeah. With a deed restriction. But the other caveat to these 3,000 units that we currently have listed that we know right now.
Yeah.
That have some deed restriction is maybe in that work group too, to pull out or define the number of units that are, how long is those deed restrictions? Are they 20-year or are they 50 years? And when are they looking to be recapitalized? Because what we're seeing is a lot of deed restrictions, especially out in the with private owners. They're not looking to, keep those units affordable. And they can't recapitalize.
Let me just mention, this touches on, so I've requested from Home Forward, from Metro, from the county, and from the city that we pull together a data working group. And what we would do in that data is not only look at how many units, but it would be each unit, how many bedrooms, what the expiration date on the affordability is. So we can really capture a much clearer sense of the volume of housing that we have that's low cost. We're not at this moment looking at what's in the market at this price. So I think that's a separate important piece of the conversation, is what does the market deliver that's low cost. But at the moment, what's regulated is where we're going to focus. And I think we can pull that together fairly quickly because we do have a lot of this data already, and we're going to try to move it quickly So we can come back with, and it would be a shared database that all of the public agencies can all tap into.
Thank you. Commissioner Singleton.
Thank you, Helmy. This is, because I'm a nerd, I was following everything you were saying. I think one of the things that I want to make sure is I want us to really examine, should this be a regional conversation, right? We do regional housing needs analysis and a regional production strategy. So how much are we not duplicating and what can feed into that more regional approach? So I think I helped write the RENA, so I know we're supposed to be talking about the number of households or number of units that we need for people experiencing homelessness. And so why we don't have that number is a little confusing for me. I would like to see us, I think it warrants at least a conversation of that more regional lens. I can tell you from doing the work in the field, I housed a ton of people in Washington County, and I think that we can't ignore, even though it's not controlled by us, that we're housing folks across all the counties. So I would love to maybe spend some more time figuring out, yes, the data piece that you're talking about makes a ton of sense. And does it make sense to make it a little bit bigger? I'd love to know Metro's perspective. And I think particularly as Metro is talking about some shift in governance about both housing bond and SHS, there's opportunity to utilize what they're doing to help us with our strategies, since they'll be really pulling in some different lenses and expertise around the regional housing production strategy.
Yeah, I think, thank you for that. That's actually a really important part of the conversation. One of the challenges is that, you know, at the Portland Housing Bureau, we look to the planners by income. We're not forecasting the population. So I turn around and I look to the state department and PAS stand for, and particularly Bureau of Planning and Sustainability to figure out the need. And one thing that happened this year that surprised me was that the estimated need of deeply affordable housing dropped by 75%. And I was like, what? Why did that drop? We still have, the number was actually below the number of people that were homeless. And I inquired both at the state and at BPS about it. I said, what, this is not making intuitive sense to me. How can it be that for the next 20 years, we only need 14,000 deeply affordable units when we know there's 17,000 people who are homeless? And what I learned in that is on the estimating is they allocate the deeply affordable across the region. So the estimated need for housing, for deeply affordable housing, is sort of spread across the entire region, even though the homeless population is in Multnomah. So I was like, well, okay, then we have to have a strategy that means we're housing people in other parts of the region. We should be talking at a regional level. And I think Metro is exactly the right body to help us work through that question. I specifically put it to BPS to please come up with another number that is more rational, which is why we have that range, because these ranges are from BPS saying on the high end, if you really look at our population, you're probably going to need closer to 26,000 units of deeply affordable housing in Portland. On the low end, that's the state number. So I think you're right. I think the conversation is regional. That's why we've reached out to Metro to participate in this.
Okay, thank you. Councilor Zimmerman.
Thanks. I guess to this, I think setting that number seems to make sense to me from, I think it can get a little wonky when we're in our budget processes to you know, we're budgeting up to a number versus trends, and we've all been a part of it where we get into a deal with somebody who's going to make 10 units out of their entire project deeply affordable, and keeping track of that can be hard. So I think the number makes a lot of sense for me. There were 900 other things in get into in terms of the policy and the way we want to do it, right? I think I'm on the record of saying I'm kind of more interested in like publicly owned, deepest, most, we'll never get off of public assistance world.
Yeah.
But I think that's a different conversation. So I just wanted to keep it here. The number is helpful. So many of these are trend based, but we either are or not hitting a mark every single year to get to that 20-year goal. And I think that that helps me as a policy and budget person know how much we didn't hit the mark each year.
Sorry, just to interject quickly, this is really, really helpful feedback, because especially when I think about the elected members of this committee, a lot of your work is going to be carrying water back to the respective legislative bodies in budget and policy related decisions that flow from these goals. So as we set goals at this table, you have to be able to sell them to your colleagues.
I mean, how many is the term of 91 million, right? And at 400,000 units, a unit, that's only 200, it's less than 230 units, right? So
That's not what we pay for each unit. That number was from local subsidy that we put in.
this is my point in terms of like just trying to make the numbers make sense for a person. It's not back of the napkin math, right? Because if you were to do it that way, it never transfers into it. So being able to carry water with people that I have to go back and talk to and convince that guy to put it in his initial budget, they're like, these are helpful things that number helps.
I'll start off by saying these numbers make my heart smile, because as discouraging as they are, they're the numbers that we have needed to ultimately make the decisions on KPIs and goals. Because without it, we are arbitrarily putting goals and KPIs out there that we have no idea if we can hit them or not. And similar to what Councilor Zimmerman just said, I mean, we hear the 91 million and then we instantly start doing calculations in our heads of various things. And so as I sit here today, I absolutely think we have to have numbers, because Ryan, you just nailed it. I've been sitting here thinking the whole time, how do I take this back to my council and city manager and team and sell what we need to sell to get the outcomes that we need to be successful here? And we need to understand what our starting point is and what our goals are, so that we can figure out ways of whether or not we can fund them. And funding, as you've already said, the constraint around funding is always going to be there. But the process becomes, how do we prioritize how we're going to spend that funding? And if we don't have a vision, we can't collectively figure out, how we're going to get there. I tend to be overly optimistic on many, many things. And that's probably going to perennially be the case. So, for me, these would be stretch goals. Taking a look at what can, Lord forgive me, but you said something earlier that I really can't get my mind around the word can't. You said we can't achieve something. And I just, from where I sit, and I'm not calling you out for that, it's just the word can't. I said I'm overly optimistic on many, many things. In my perspective, can't doesn't exist. That comes from my mother. And so ultimately, we can achieve anything we want to put our minds to. And especially with this August group and this collective body, we now can achieve something I don't think we've ever been capable of achieving independently and disparately as we've approached this problem previously. So I'm super excited about hearing this information and now understanding the gap and what we can achieve. And then how do we reallocate? Because this is going to be a reallocation of resources. It's not going to be an allocation because we're constrained. So it's going to be a reallocation. So the better we can tell the story and we can outline exactly here what we believe is going to get us from where we are today to where we need to be, is going to make it so much easier for me to go back to my council, to my city manager, and say, here's what we got to achieve. How do we contribute to this? How do we do our part to catch the vision? Because I think what's missing now is everybody, I shouldn't say everybody, the majority of folks that I communicate with, and the ambiguity around what we're doing disallows them to understand exactly where we are and where we're going. So I'll wrap up just by saying, as I sit here today, this has been something that's been missing, I think, in the conversation. I don't have quite enough yet to be able to even opine on what these goals and KPI should be, because now my head's spinning between, okay, wow, we need this many units ultimately, we need this percent of the population should have access. All of these things are spinning now, and I've got to be able to digest that and then contribute. And I think in a way that really becomes realistic. So I apologize for not, being able to give you some specific numbers that have come in my head, but I'm telling you right now, I think the combination of what you just gave us and the discussions that we're now having, I think are going to produce something pretty extraordinary that's going to allow all of us to begin to get behind what we're going to produce in these KPIs and these goals.
Can I make one more comment? Basically, is that, I shared with you the numbers for the deeply affordable housing. What I didn't share with you, but also should be considered, is that there are, just in the city of Portland, 35,000 households paying more than half their income on rent. And that population is at risk for homelessness. And I think with the pressures that are happening with federal funding, we're going to see the pressures on eviction are high. And so I also think that when we start setting goals, we can't only set goals for the 30% deep affordability. We still need to continue to expand the supply of affordable housing for slightly higher incomes. And that'll also be part of our goal setting process that, I didn't reveal today. This is really just about homelessness, but I think it's important.
Thank you. Well, then the folks who are on the precipice of experiencing homelessness are absolutely like part of the conversation and the considerations as well about these things, especially when we're looking at real challenges to the dollars that we have for eviction, for considering the different ones. Commissioner, you're
I put it down. I thought Helen spoke, so I jumped right in there and she spoke. So
okay, go for it.
What I'd like to talk about is these are 4 critical KPIs. That's a milestone. It's an important piece of information, but I'm hopeful we can create more of inch stones. What can we do today and post on this board at the front and say, what are we here to do right now? If we do this with Helmy, we're doing this at our housing incident command meeting and we're tracking things. What can we do today? What's available today? And how do we get somebody into that vacancy, which is not the 20-year goal, it's the next 20 days. And I just want to kind of bring it back. If we're going to be tracking this, and this is one of the 4 that we bring up, I would ask why. It's more of an environmental as opposed to something we could do for the vital few. When we're running a high-performing organization, you have to know where our vital few that we need to be accountable to right this minute. And if this is one, then we need to have a clear diagnostic, but it's so long-lived and so capital-intensive, it's not going to allow us the ability to move right this minute, to address the crisis on the street right this minute. So I don't know, it's important, I just don't know if it's germane to what we're trying to address right now. Yes, it's absolutely. So we need a table just on that. But is it what we're trying to do in the SOC to address the crisis on the street and the unsheltered homelessness, which we've been talking about housing this entire meeting? It's a 2-pronged approach, shelter and housing. My concern is we need to move at a faster pace to address the crisis in its twin approach. So I know we'll talk. I'd like a moment or two before we convene as well.
okay. So I'm going to go to Pierce because he hasn't spoken on this topic yet, and then go to Commissioner.
First, I want to appreciate the conversation. The one thing that I haven't seen in the KPIs around, especially around housing, is cost. So cost here by system. So I think it's, shelter, PSH, and affordable housing. And then I think we need to be matching that against the national average. And we should be attempting to beat it, right? That's a policy conversation because that ends up tying to systems, right? We know that ties to a system. And then the other one is, how does the county play in increasing the quality of jobs for this population? So jobs for those that are in the system. I've faced with people, I've been volunteering at shelters where they're having jobs and then experience them out in the rural American market right now. So how are we giving them, and how does the county show up to get better jobs for those that are part of it? We know that's a lower population, but what does that look like? Is that something that we can be tracking and paying attention to and understand that can be helping people outside of this as well?
Thank you.
So, Chair, if you don't mind for a second, I just want to be clear. These KPIs are looking at the entire system. That absolutely includes housing. It is 100% germane. I told the city staff I'm open to a staged approach. Like I haven't heard TIF yet. Like TIF is coming on in 2030. I think we have good estimates about how many units that would be in all of the new districts coming online. So stage is open, but this is definitely a piece to it. I mean, when you can jump to number 11, exited to where? Like we need housing. It has got to be part of this. So I am asking our city partners to do some really good work between now and October 8th. So on October 15th, we have clear direction on the KPI.
Sure, but we're looking for an outcome today. This is an important bit of information. It's going to literally take
Yeah.
years and years. We need to focus on it. But we also have to address the crisis right now. And I really want us to talk about metrics that are going to allow us to do a system diagnostic right now, right here, what we can do today.
So I think, a couple of pieces, I think there are other KPIs that are address what you're talking about in here. We just didn't talk about them today. Let me finish.
Good.
And we've spent most of my time at the SOC talking about shelter and unsheltered. This is the first time I've had a housing conversation, so I appreciate having space for that here. I've got a couple of things, what I heard from other people. One, on the existing vacancies at 60 and 80%. I think that is a potential prevention strategy, Helmy, to what you just raised of folks who are paying over 50% of their income. Are there opportunities to move that into subsidies so that we can address prevention in a way when we know we have less resources to actually pay rent at the market rate? The other part around the vacancies is I would love to know an evaluation of our PSH vouchers and how many are in private market. I think there's a cost saving opportunity to move folks into these regulated units and potentially have additional PSH vouchers available because we're not spending as much in a private market subsidy. The cost piece as well for development, I think we need to start with an inventory of publicly owned land. The cost of land is such a huge driver of the cost of development, and I don't think we've done that inventory for all publicly owned land, state, county, city, metro, the port. The ports have more land than I ever knew. It's kind of astounding. So what are those opportunities I think would be really helpful? And then, Peter, to your last point around workforce, we just completed a workforce table where I worked with the trades as well as manufacturing to look at opportunities to get people into those types of family wage jobs and explicitly connecting both to anti-poverty work. So that's that eviction prevention component, but also to our folks exiting homelessness. So I will share more later on that, but it is also a phase where we'll have additional conversations with different industries over the next year or so, Commissioner Jones Dixon and I. So I totally agree. Would love to pull you into that conversation because I think we have some really concrete ways that folks can actually get into those jobs. And one part of the conversation was I'd rather pay somebody's rent for a year so they can actually get a living wage job than to keep having to help them over their lifetime because they're stuck in poverty. So that's really the focus of that table. I think it needs to be we started where I had some relationships with the trades, but there's more than just the trades that folks can get into.
Thank you. And turn it back over. Anything more on the benchmarks?
So I feel like we are moving forward with our recommended approaches on all four.
Oh, so I don't know that we've had that conversation.
Okay.
So I think going back to the last slide, so
Last slide.
or yeah, the one previous to this. So this, thank you. So these are the four four KPIs that and staff has recommended that this is how we approach the setting the benchmarks for these different things. But we can have conversation about, do we agree with these approaches? Do we want to see a different benchmark used, a different option of benchmark used for these? We can have that conversation now. People can take a look at these, read through the memo, and we can come back and have that conversation next month, which I think will give us all a chance to really do these things a bit more. But this is where we need to be heading to be able to get agreed upon goals for these KPIs that we've all unanimously, I think, approved. If I remember correctly, and just be able to really set in stone, like, what are we going to be working towards? And then again, directing all of the work of all our various organizations to be reaching.
And to be really concrete about it, the next step for us to be able to get you to that decision-making point is to help me give you some insight into the complexity of modeling around just that single KPI. Like, how would we actually go about modeling the 30% unit KPI? There's a similar level of modeling that would need to go forward for each of these KPIs so that we can help you set SMART goals that are actually achievable instead of just aspirational goals. And so having the directional indication of like, generally you're moving in the right direction and we want you to bring us that analysis to inform what the actual goal could be. That's ideal for us. So that we're not bringing you a bunch of scenarios that we spent a lot of staff time modeling that you're like, no, that's actually not how I wanted to measure this goal at all. So as you look at the memo, I think that's what I would encourage you to be thinking about is like, yep, this feels roughly right. Go do the hard work to get us some numbers attached to this. Versus like, wow, I actually don't think this approach is correct. And we need to think about a different approach. That's where we'd want that flag. And so I think Jillian's point was getting at on these 4 that we discussed today. I didn't hear folks saying, I think you're in the wrong direction on these 4. It was help us understand more so we can go away and start modeling on those. Testing that in the room. And then if you have any concerns about all of the other ones that are listed in the memo, you can get feedback to our team.
Thanks. I think that's good. I can come back with it. It's important. I just want to, one thing that's a risk for us as a group is if we try to make everything SMART, specific, measurable, achievable, relevant, time bound. There was nothing smart about JFK saying we're going to the moon. And I think that in this housing production discussion and some of the stuff that my colleagues are doing on the city council, if we try to fit a solution into the systems that we've been working in, I think we're cutting ourselves off at the knees. And so I think it's the staff's job to say, ooh, our system doesn't even know how to interpret that line of vision. But it's also, I think, this body's job to say, if we sense something needs to be bigger, that is aspirational instead of strategic, that we should feel damn comfortable doing it. Part of my worry is that we have over strategized instead of over aspirationalized in some of these spaces. So I just leave that there because I think on this housing in particular, we need to do something quite drastically different.
Thank you. There are a few more slides.
Actually, sorry, the last 2 slides that are there, we're only illustrating what you see in the memo. So we don't need to go through those in the space today. Yeah, better detail, right?
I don't need an answer today. I just want to know why 3 years tends to be what we see. So if we can talk about that next time or you can send something out, I'd be interested in why that time frame.
Yep.
Thank you, Anna, Jillian, Chair, last week. So I brought some metrics to the table, given those to you, Commissioner Singleton. We'll give them to you. I'd like to have those focused on. At Portland, we have a shelter, a housing strategy with 2 infinite command needs, shelter and housing. And what we want to do is just make sure we action both short and long term. I think these are fine goals. They are long line type goals, in some cases environmental. I want to make sure that we have those metrics that we're talking about. If they get voted down, I get it, but they're more diagnostic on how the system is working right now. Commissioner Singleton, the things you asked for several months ago have piqued my interest. They are really important data points that I'm hopeful, Lori, you can pull out every month and we list at the beginning of every meeting what the diagnostic of the system is doing right this minute. So we're not talking in a long-lived approach, but we're doing 2 problems, shelter and housing, and we're looking at those data points. And we agree to the data points, and then we do everything we can to meet those data points in the next meeting. But I want to just kind of talk about the Oasis is opened. We have 100+ guests there. The health and the safety at the shelters around it have reported positive. The area is less blighted now. You keep driving by the Greyhound Station, Union Station. It's looking better by the day. We've opened 630 shelters. We have 6 more getting ready and prep to get opened right now. So we're moving forward. We have a new person down policy that if you see somebody lying on the street, we're changing our public safety focus to rush to that person. So we're really focusing on helping people into those needs, something to just really focus on. inflow and outflow. Our reunification program last month, 35 people reunified. If we housed them, it would be $17.5 million that we avoided. If we did rapid rehousing, it would have cost us $1.2 million. So we're rapidly helping people get back to the families around the nation. And then we had a hospital or a treatment facility that released somebody to report streets that were outside of our county. We sent a cease and desist to them, and I'm meeting with that hospital network over in the out-of-state location to talk to them about how we humanely care for people. We don't do hospital dumping or treatment dumping into Portland, really trying to focus on that. So those are things I really wanted to let everybody know. Celebration are around Brandon Westerman, Skylar Rock. Now we're really trying to assist the system with positive outcomes right now, right here, to really take the pressure off of us as we do this hard and important work. So thank you, Jillian.
Thank you so much, Mayor. Really appreciate that update. That's happening. Okay, so thank you. So any we're losing folks. Folks that everybody's trying to get to their. Okay, so our next meeting is on Wednesday, October 15th at 8:45 a.m. We will let people know what that where the location is. But again, please come back with some recommendations on these specific benchmarks, and we will focus on that conversation. Thank you.
Thanks, Chair.